The broadcast is now starting. All attendees are in listen-only mode.
Good evening and welcome everybody to this Neuro-Advanced sponsored webinar with ICANN, and it's going to be on why can't I concentrate? So I hope you've all been concentrating whilst we just sorted out a slight technical glitch. So apologies for being a few seconds late. And I would like to hand you over to Jo. She's very well placed to look and dig into the functional medicine to get us right to the roots of why people might be struggling with focus and concentration, and looking at that sort of neuroinflammation. So without further ado, just to mention, my name is Sarah Sharp. I am from Neuro-Advanced, and I'll be in the chat box. If you have any questions at all, you can type them into the questions, and we will send those to Jo at the end of the webinar. We're probably not going to get time to go through them at the end, but we'll send them to Jo, and then they can be sent out with your recording and your follow-up and your certificate from ICANN. So thanks very much, Jo. I'll hand over to you now.
Thank you, Sarah, and good evening to everybody. And I do apologise for the late start, but I hope it will be worth the wait. So really thinking today about our cognitive function, our neurotransmitters, the impact of neuro-inflammation, something that you may have heard of as a bit of a buzzword, but very much is an underlying driver to many chronic diseases. Now, I was trying to think, how can I apply our knowledge of neurotransmitters and the impact of neuroinflammation onto so many diagnoses, so many bunch of symptoms. And really this evening, I am focusing on neurodegeneration and neurodiversity. But please hear me when I say so much of what we talk about, we could apply to other neurological conditions, from MS to PANS and PANDAS to the aging process, but really need to dive in deep to make sure that we're thinking about being able to make a difference from a functional medicine point of view. And why I picked neuroinflammation and neurodiversity is because of the overlap between the two. How often have you heard that saying, the brain is on fire? And like I said, we've got to think about modern day living as a driver of that neuroinflammation. So let's kick off by talking about the gut-brain axis. It's an integrative physiological system amalgamating the endocrine, the immunological, thinking about nutritional impact, thinking about efferent and afferent neuronal signals between the gastrointestinal system and the brain. So what can impact this gut-brain axis? Well, lack of sleep, dietary protein reactivity, and we might sort of touch upon how we can test for some of them, maybe through the Cyrex testing. Infections, particularly a focus on like viral infections like cytomegalovirus, Epstein-Barr virus, vector-borne illnesses, thinking about chemical triggers, definitely on the increase, thinking about inflammatory diseases, inflammatory diets, the typical Western diet, standardized American diet, thinking about psychological triggers and emotional imbalance. So starting off by thinking about neuroinflammation, like I said, you can apply neuroinflammation to so many conditions, whether that's of children right through to the elderly. Like we're looking at that whole spectrum of patients now. So you might get those subtle neuroinflammatory symptoms like brain fog, variations in mental speed, reduced brain endurance, just haven't got the ability to keep focused for very long, brain fatigue after exposure to specific chemicals, scents or pollutants, brain fatigue after exposure to specific food proteins, so maybe noticing not just a postprandial slump as in my energy goes down, but really thinking about postprandially, what happens to my brain and my cognitive function. And then we're moving on to more moderate neuroinflammatory symptoms, maybe changes in mood, inability to concentrate for longer periods, sleeping maybe more than 8 hours a night, lethargy, fatigue, lack of motivation, lack of appetite, malaise, and an inability to be physically active. And then we're moving into severe neuroinflammation. And delirium, confusion, disorientation, dementia, personality changes, coma and seizures, they're pretty end results. Difficulty speaking, trembling, tremors, involuntary twitching. Now, some of this may be irreversible depending on the condition, like in Alzheimer's, but maybe something that's experienced maybe after a traumatic brain injury, and you might get acute, very sudden onset. Maybe you've got a rugby player that's had a head injury, or a child that's had a cycling accident. And certainly in all of these, whether it's mild, moderate, or severe, you've got to be thinking about identifying the potential lifestyle, dietary triggers, and thinking about a full body systemic approach. Now, think about our blood-brain barrier. It's a component of the neurovascular unit and acts as the blood-brain interface, mediating communication between the central nervous system and the periphery. The blood-brain barrier separates the circulation from the brain, allowing for protection from the transport regulation of serum factors. The blood-brain barrier is not just a physical barrier due to the presence of specialized tight junctions, just like we talk so often about those tight junctions in the gut, or even nowadays in the bladder. But we know that we've also got that ability to get a permeable blood-brain barrier. So then we've got agents, whether that's viruses, bacteria, chemicals, being able to transport through the blood-brain barrier and having neurological impacts. Now, we know, apologies, going the wrong direction now, we know that like traumatic brain injuries can lead to symptoms like acutely. So you get somebody who's had a really nasty motorcycle accident, but actually a traumatic brain injury can manifest as much as 5 to 10 years after that event. So again, when you're creating that timeline, make sure you're asking your clients, however young or however old, what or if any brain injuries they've had, including in that road traffic accidents that may not be that severe. We actually had a gentleman in our clinic not very long ago who presented with Parkinson's type symptoms, but they manifested after he'd had a accident on a bus where the bus had braked, you get the gist, very suddenly, and he'd come sort of crashing forward. Didn't go to the hospital immediately, did go to the hospital afterwards, wasn't even scanned. And then he presented with Parkinson's-like tremors, very acute onset. But when we took the case history, this incident was very, very significant. So anytime you see a case history with symptoms of neuroinflammation, you must evaluate the medical history timeline for any traumatic brain injury. And this is most concerning if the patient lost consciousness after the injury. Also take into consideration diabetics, smokers, anybody who's got inflammatory bowel conditions, pro-inflammatory diet, hypoxic anemia, vascular inflammation, and potentially low antioxidant reservoirs, which you might see that evident when testing things like A2-HDG and lipid peroxides as part of a metabolomics or a NutriVal test. Now, patients with primed glia and reactivation of the neuroinflammatory response will have symptoms specific to the regions of the brains that were injured or primed. In this gentleman, it was quite close to his brain stem, so it impacted his movement and his speech. So again, that would be evident in a scan where you may have seen a previous bleed on the brain. Here we're looking at, when we're thinking about pro-inflammatory mediators and the activation of neuroinflammatory processes. Now, it's quite hard to be able to measure all of these markers in one specific test, But what we might be looking at is increased LPS. That's definitely a test that I look into. Increased interleukins, increased CRP, and then thinking, like I said, about antioxidant status, because remember that those antioxidants can quench that free radical damage. So when we're thinking about this bidirectional gut-brain axis, which is so important, the microbiota is now seen as a key component of the gut-brain axis. And disturbance in the homeostasis or dysregulation of the gut microbiota impacts the brain axis and have been implicated in various immunological, neurological, and psychiatric conditions. Many clinical cases of unresolved leaky gut are secondary to chronic traumatic encephalopathy, so inflammation of the brain. You cannot just fix it by treating the gut alone. You have to work in, it's a bidirectional relationship, so you have to work both at the brain and at the gut level. So in order to fix the gut, you need to fix the brain. In order to fix the brain, you need to be fixing the gut as well. And then we've got these 4 mechanisms by which the peripheral immune system communicates with the brain. So we've got in the diffusion pathway, blood-derived cytokines passively traverse the blood barrier at leaky brain regions. We've got the transportation of the peripheral cytokines, which occurs by an energy-dependent process involving transporters integral in the blood-brain barrier. Circulating cytokines bind to endothelial receptors to elicit the release of immune molecules, such as cytokines, it's your reactive oxygen species, directly in the brain regions. And then we've got the peripherally produced cytokines directly stimulate the vagal afferents from the liver to central responses throughout the gut and the brain. So when you look here at that neurology of gastrointestinal activity, this is a really good sort of pictogram to be thinking about when we're trying to get, when we talk about vagal nerve activation, we really want to be thinking about, well, how does that vagal nerve activation work? At a enteric nervous system, generates intestinal motility, generates enzyme release, and without those functions, none of our neurotransmitters are going to work optimally. I'm not saying not at all, but I'm certainly saying not optimally. So yes, we need to make sure we're taking away any metabolic drivers of altered neurotransmitter function, but we really need to think about optimal function. So when we think about metabolic conditions that impact our cognition, this is at any age. Sleep disorders, whether that's lack of sleep, so they're thinking about, I certainly know this as a parent to a child that isn't, or 2 children, one's much older, that haven't been very good sleepers. In that chronic sleep deprivation phase, I've had to work harder to get my brain to concentrate. I've had to give my brain more brain nutrients to make it concentrate. So, you've got women who are trying to have powerful jobs on very, very little sleep. What impact's that going to have? Margaret Thatcher told everybody how she trained herself to only need, 3-4 hours sleep a night. She was like proud of the fact that she trained her brain to only need that. And then what was her ending? Neurological disorders. So there's got to be a link in there, hasn't there? Well, that sleep deprivation and high stress, maybe cumulatively. Circadian rhythm dysfunction. So when you've got people working nights, working shift workers, flying through different time zones, insulin resistance. So thinking not just the diabetics, look at your HbA1c, but also look at your fasting insulin, your fasting glucose, your estimated average glucose, because they will all give you part of the story. Hypoglycemia, whether that's functional hypoglycemia or reactive hypoglycemia, hypothyroidism, particularly Hashimoto's, prime glial cells. Again, think of your traumatic brain injuries, blood-brain barrier permeability, systemic inflammation. So think about your autoimmune patients. Think about patients who've got viral insults and how that could be driving those inflammatory processes. hypoxia, whether that's because they're iron deficient, anemic, whether that's because they've got poor circulation, or respiratory disorders, think sleep apnea in there, and then sort of the end result, neurodegeneration. So when we go into thinking about sort of starting off at life, the brain is not a homogeneous organ, rather it's comprised of multiple anatomical regions and processes, e.g. myelination, each with a unique developmental trajectory. Many of these regions have developmental trajectories that begin and accelerate in fetal life or shortly after birth. So again, we need to get that whole timeline. For example, myelination abruptly increases at 32 weeks gestation, is most active in the first 2 postnatal years. So thinking about what journey has that child been on up until about 1,000 days. So we talk a lot about 1,000 day, which is from egg meet sperm to about a child's 2nd birthday, with regard to development of a healthy, diverse gut microbiome, thinking about all those lovely bifido strains being cultured. But we also need to think about that 2 years as very important sort of brain development. Keeping brain areas on development trajectory is critical not only for promoting behaviours served by the individual regions within the brain, but also more importantly to ensure time coordinated development of brain areas that are designed to work together as circuits that mediate the complex behaviours. Early life events including nutritional deficiencies, so think all of them, but particularly think go through my head was your iron, your zinc, your essential fatty acids, your B vitamins, your vitamin A. Toxic stress can have differential effects on developing brain regions and processes based on the timing, dose and duration of these events. So like I said, you've got to be thinking about those key nutrients. Iodine would be another one. And yes, okay, you may or may not have worked up. I think I've worked with one case of fetal iodine deficiency. It's very, very rare, but you've also got to be thinking about the neurological impact. So those of you that might be working with children with autistic spectrum disorder, with ADHD, with pandas, okay, it's not about putting blame on parents, but it is about going back to the very beginning and looking at why we've got susceptible individuals. I started working in ASD, autistic spectrum disorder, some 25 years ago as a behavioural therapist. That was my original profession. And back then we were looking at statistics of about 1 in 900. And now we're down to statistics in different areas, like different countries, of anything from sort of 1 in 19 to 1 in 38. That's the sort of statistics that we're working within. Yes, there is better diagnosis. Yes, there's more adults being diagnosed, but it also has to do with multiple factors, and that's our job to break into what those multiple factors look like. Prenatal maternity anxiety increases fetal exposure to maternal cortisol. This exposure affects offspring neurodevelopment involving the amygdala, the prefrontal cortex, hypothalamic pituitary adrenal axis, which can increase the risk of behavioural and mental health problems later on in life. Now, that isn't just about ASD, that could be about anxiety, that could be about depression, that could be about other neurological presentations. Evidence suggests that the microbiome and epigenetic changes as described are involved with the mechanism of prenatal stress, with suspected downstream changes on neurotransmitter systems. The effects of prenatal stress can be enhanced by variations in maternal genetics, impacting other neurotransmitter systems. The specific mechanisms are less established for maternal gestational immune dysregulation. If it is indeed revealed that prenatal stress and maternal immunity are related, interventions targeting prenatal stress exposure might also have an impact on maternal immunity. So we really do want to think of how we, in autistic spectrum disorder, which is a complex neurodevelopmental disorder, which we know has, yes, a strong genomic base, as in you will often see more than one young person or adult with ASD in a family, but it is much deeper than that. And thinking about, yes, genes have a part to play, environment also has a part to play, chemical exposure, but that also important immune system. But statistically, younger siblings of children with ASD have a 15 to 20-fold increased risk for developing ASD compared to the normal population, and 20 to 30% of younger siblings who do not develop ASD will develop other developmental delays. So this is where understanding those genomic risk factors are really vital. So when we look at this diagram here, when we're looking at the enteric nervous system and glial abnormalities in autism, so we've talked a lot about, so much research out there on glial priming and Alzheimer's disease, but now we're able to dig a bit deeper into sort of unanswered questions which could indicate glial priming in autism. And again, is this a chicken or is this an egg? Is this something that a child was born with, or were those glial cells primed as a result of chemical and environmental exposure? Think there again, proteins in foods like being introduced to gluten or gliadin and to dairy, to the casein, particularly as part of that priming somebody who was born with genomic instability. In this paper here, although ASD is not considered as a typical autoimmune disease, self-reactive antibodies or autoantibodies against a wide variety of target cells have been found in a subset of ASD patients. In addition, autoantibodies reactive to fetal brain proteins have also been described in the prenatal stage of neurodevelopment, where they can be transferred from the mother to the fetus by transplacental transport. Again, we used to, even at the beginning of my professional career, used to think about the gut microbiome from birth and beyond, but we now know that the placenta has a ability to transfer not only good bacteria but chemicals. Potential inflammatory cytokines can pass through that placental barrier. Now, this here is a graphical representation of the maternal fetal interface in the placenta. The human placenta is formed by a fetal component, mainly containing villi and maternal components, consists of spiral arteries, and the chronic villi have a basal membrane that is anchored to the inner sort of like the cytophoblast epithelial cells, which in turn fuse to form the outer layer. Now, what we know is it's this outer layer that that has the ability to transfer, but it isn't just, like I said, it isn't just cortisol or a mum's level of serotonin that we're thinking about here. We're thinking about how individuals with autoimmune diseases, rheumatoid arthritis, type 1 diabetes, celiac disease, autoimmune diseases in both parents were associated with increased likelihood of autistic spectrum disorder. So thinking about, so what impact, not just, okay, we know HLA DQ2, DQ in celiac disease and type 1 diabetes, but actually rheumatoid arthritis, what are we looking at? We're looking at the transfer of inflammatory mediators through the placental barrier in combination with genomic instability, in combination with proteins being exposed in that early couple of years of life. So the proposed effects of interleukin-6 on the prenatal environments. So this is quite a simplified representation of the downstream effects of interleukin-6 production as a a consequence of maternal infections, which arrows indicating the sequence of events in various body components. The placenta is shown in the light orange at the top. So we know through that level, that interface, that maternal infections can be transferred through. We're talking quite a lot about this with particular reference to COVID-19. Now, this is still very early in its infancy of research, because bearing in mind, parents who had COVID-19, their children are so unlikely to be fully in the diagnostic criteria of this country, as in a lot of children aren't receiving that diagnosis until 5 or above, even if the child is exhibiting symptoms of ASD, ADHD. But when we're thinking about maternal crossover, infection is massive. So watch this space. Maybe we'll come back together in 3, 4, 5+ years and see if there is a downstream effect on that as a maternal infection. It was found that individuals diagnosed with ASD have alterations in immune cells, such as T cells, B cells, monocytes, natural killer cells, and dendritic cells. So we're seeing from a very early age, these children are exposed to immune dysregulation and to inflammation. So if we go on and think about ADHD, we know it's a neurodevelopmental disorder affecting about 7.2% of children below the age of 18 globally. And this prevalence keeps increasing, or has kept increasing over the last 20 years, with, yes, granted, more and more adults going through diagnostic criteria. So what are those causative factors that we've been able to highlight so far? You can see in this table maternal exposure, actually in pregnancy, bleeding in pregnancy, prematurity, low birth weight, low APGAR score, infections, exposure to lead or other toxins, nutritional factors, psychosocial adversities. So when thinking about ADHD, we've got to think about, well, what were those early in utero risk factors? So maternal stress during pregnancy, prenatal exposure to tobacco, that isn't just from the mum, that's also passive smoking, prenatal exposure to alcohol, prenatal exposure to environmental toxins, prenatal birth or low birth weight. Then thinking about exposure to different chemicals. And remember, as chemical exposure has gone up, so has diagnoses of neurodiverse conditions. So there has to be some sort of correlation going on. Malnutrition during development, unhealthy microbiome, lacking diversity of key strains, neuroinflammation, and lack of diverse brain stimulation. So there is evidence to show an increase in incidence of atopic disease, including atopic dermatitis, allergic rhinitis, eczema, and autoimmune disease in ADHD patients. Individuals with these atopic diseases also have a 30 to 50% greater chance of developing ADHD in later life when compared with non-atopic children. Several studies have reported that heightened levels of circulating pro-inflammatory cytokines, such as interleukin-13, 16, TNF-alpha, were found to be related to AD symptoms. And this evidence suggests a common pathophysiological mechanism underlying both atopic diseases and ADHD, via the link of the immune system. So we have talked about, I've been lecturing for more than a decade about the link between the gut and atopic conditions in children. Now we've got to add that extra arm into the equation and go, those individuals are at greater risk of some neurodivergent conditions. Now, so I wanted to then go on and look at, well, look, if you've got early stages of neuroinflammation or neurodiversity, what's the long-term implications of that? And found this study quite interesting. To the best of our knowledge, this is the first study to explore the associations of ADHD, a neurodevelopmental disorder, with Alzheimer's disease and any dementia. neurodegenerative diseases across generations. We observed that relatives of individuals with ADHD had an increased risk of developing Alzheimer's disease and any dementia compared to relatives of individuals without ADHD. The associations attenuated with decreasing genetic relatedness, so parents, grandparents, and uncles and aunts. The risk of having early onset Alzheimer's disease associated with ADHD was higher than for late onset Alzheimer's disease. ADHD could be considered a potential modifiable risk factor for Alzheimer's disease and dementia. And our study highlights the importance of advancing the understanding of ADHD and cognitive decline in older adults, and if verified, calls for investigation of early life psychiatric prevention and the development of neurodegenerative diseases in older adults. Now, what we've got to realize is in the last 20 years, there has been so much research, there's been so much increase in diagnosis of young and adults of ADHD. So what we've got to see is what is the future 10, 20, 30, 40 years. And we can be at the cutting edge of that by really understanding what we can do to quench neuroinflammation. So that's why it's so important to think about viral infections and what can we do to lower viral infections. So this figure here looks at that maternal viral infections obviously alter immune response, generating pro-inflammatory cytokines, interleukin-1 beta, interleukin-6, interleukin-17, and these cross the placenta and generate neuroinflammation in the fetal brain. During viral infection, molecules of the viral surface are recognized and trigger a cascade of events in the infected cell. Host receptors recognize viral molecules or nucleic acids and initiate a signaling cascade that ends with a nuclear translocation of transcription factors, such as the interferon regulatory factor, IRF3, which induce the synthesis of type 1 interferons and which are ultimately released into the extracellular environment. And these the interferons are detected by cells in the innate immune system. Our innate immune system cells, such as macrophages or dendritic cells, recognize these pathogen-associated molecular patterns, PANTs as we know them, and damaged-associated molecular patterns, DAMPs, and they also respond to cytokines such as interferon and activate signaling pathways via NF-kappa B to generate pro-inflammatory cytokines. So when thinking about ASD, thinking about schizophrenia, thinking about neurosensory alterations, thinking about Alzheimer's disease, dementia, we have to be thinking about early exposure to viruses and what can we do from a regulating that immune system, whether it's Th1 dominance, herbs like astragalus, echinacea, licorice, maitake mushrooms, Th2 with grapeseed extract, pine bark extract, Th3 with vitamin A and vitamin D. We have those skills in our kit bag. And whilst recently we've just discussed the impacts of COVID-19, we have to learn that other viruses that preceded it, such as cytomegalovirus and influenza A virus, have an impact potentially in more vulnerable individuals on fetal neurodevelopmental conditions for several years after exposure. Now, so much of this research, like I said, is about early onset autism, ADHD, but we've got to keep watching what happens over the next decade, 2 decades, because how quickly is the exposure to these increased interleukins going to present as a neurological condition in that offspring? And the answer to that is nobody knows, and nobody can know, because this is the first of its type, a global pandemic. And again, I was trying to find research out there, which I'm going to be honest is quite well hidden, about the impact of obviously vaccination on autism and ADHD. And again, it's sort of deep away, but it's in its infancy. So from a functional medicine point of view, we need to be thinking about blood-brain barrier permeability, infections, hypoxia, hormonal imbalance, immune dysregulation, environmental toxins, and oxidative stress. Now, we've talked about BDNF before, and we can link BDNF to so many different presenting symptoms neurologically. Concentration, obviously neurological disorders like Alzheimer's and dementia. We can think about BDNF, low BDNF levels in behavioral problems. There's certainly quite a lot of research out there in other acute onset neurological symptoms. BDNF gene provides instruction to making a protein found in the brain and spinal cord. Obviously, the BDNF itself, and this protein promotes the survival of nerve cells, neurons, by playing a role in the growth, maturation, and maintenance of these cells. In the brain, the BDNF protein is active at connections between nerve cells, that's our synapses, where cell-to-cell communication occurs. Synapses can change and adapt over time in response to experiencing characteristics called synaptic plasticity. And the BDNF protein helps regulate synaptic plasticity, which is important for learning and for memory. So in the brain, BDNF is active in the hippocampus, the prefrontal cortex, areas responsible and vital for learning, memory, and higher thinking. Hence why BDNF is important for our long-term memory. BDNF helps to support the survival of existing neurons and encourage the growth and regeneration and creation of new neurons. So when we're thinking about, well, what can we do to support BDNF? That's where our butyrate, our quercetin, even caffeine come into play. Also thinking about curcumin, which produces neuroprotective effects by activating the BDNF-dependent enzymes. Niacin, magnesium. There are so many different genes involved in regulating BDNF. And we're going to keep learning about these different pathways. So you can see here the many different benefits of BDNF and why it is so important for us to be thinking about them. Now, whatever the neurological condition, we know that air pollution impacts the brain, whether this is on dementias, whether this is on neurodegenerative disorders like Parkinson's, cognitive dysfunction and memory impairment, mental disorders like depression or schizophrenia, neurodevelopmental disorders, strokes, headaches, migraines, and epilepsy. So ascertaining what people have been exposed to from a chemical, from a road traffic exposure is really important. Then thinking about impact of alcohol. Patients with neuroinflammation and or neurodegeneration of the cerebellum are more sensitive to alcohol and more likely to get hungover. Patients with pre-existing neuroinflammation of the cerebellum can't handle alcohol. So thinking about patients that say that they get significant hangovers, yeah, it might be something like your GSTM1, GSTP1 polymorphisms, but it also might be linked to neuroinflammation. Toxicants in the environment can directly harm the components of the microbiota, but can also be modified by the microbiota to become more or less toxic to the host and to the microbiota itself. So this is where really digging down into what is in your toxic bucket. Here it looks at sleep deprivation reduces cognitive capacity despite the use of stimulants to restore function like caffeine. Loss of sleep may affect specific cognitive systems beyond global cognitive declines and impaired attention processes. So talked about environmental toxins. I'm just going to leave this as a slide for you to keep in your reference. Make sure you're asking your clients those questions. Make sure you're doing questionnaires like MSQs, toxic exposure questionnaires, to get what are their symptoms and what have they been exposed to, not just today, but historically. Remember, many toxins are fat loving. They'll sit in fat cells and that's where they will stay. And then we've got to think about molds. Human exposure to molds can cause neurological and neuropsychiatric signs and symptoms. Any of these clinical features can partly mimic or be similar to classic neurological disorders, including pain syndrome, movement disorders, delirium, dementia, and disorders of balance and coordination. Human exposure can be really, really multifaceted. And then we're thinking about glutathione. I mentioned about those SNPs regarding alcohol, but in summary, data obtained in the study found that the loss of glutathione plays a significant role in the toxic effects of mercury exposure. So if somebody has been exposed to mercury, whether that's through amalgams, whether that's through heavy metals, whether that's been passed on through the placental barrier, which I think is so often the case, then we need to think that individual for detoxification. Now, I've mentioned stress. I mentioned a lot about maternal stress, but what now about our lifetime exposure to stress? Chronic stress primes the microglia and induces an inflammatory response in the adult brain, thereby compromising synapse supportive roles of the microglia and deteriorating cognitive functions during aging. But neuroinflammation can affect us at any age, and whilst yes, it can increase our risk of Alzheimer's and dementia, what does it do in the today? How many years, decades can we cope with being exposed to those increased inflammatory cytokines and mediators before it has a sudden acute impact? We found that elevated cortisol was associated with poorer cognitive performance, in particular with poorer memory performance, independently of life events. More research there for you about stress and neuroinflammation, the influence of stress, neuroinflammation, and alterations in brain structure. The microbiome, a key regulator of stress and neuroinflammation. Again, it's that sort of bidirectional. The influence of neuroinflammation on major depression. So you cannot always remove stressful events, but you can engage in activities with your clients to reduce the impact of the stress response. That's our lifestyle medicine. And I always say to a client, I can't take away your divorce, your work stress, your moving house, your parents dying, but I can work with you to be able to handle the impact of that stress. And that's all that we can do as practitioners. So we have to work with our clients to think about sleep. It becomes very much a vicious cycle, whether that starts with dysglycemia, whether that starts with neuroinflammation, or whether that starts with acute insomnia. But that the most common cause of insomnia is dysglycemia. So really starting with basics about our client's evening meal and the carbohydrates that they're eating as part of their evening meal. Thinking about their sleep behavior is so important. Thinking about what you can be doing to reduce stress, if nothing else, in the evening. Good sleep hygiene is absolutely vital. And then thinking mainly about, you know, from a food point of view, we've got that tart cherry juice rich in magnesium, thinking about magnesium rich food. And then thinking about how exercise helps to improve sleep quality. Now, it isn't actually that beneficial to do exercise before bed unless it is a bit of gentle yoga stretching or Pilates, but it's showing like how exercise in the day improves sleep quality and quantity at night. But again, there's another vicious circle. You're exhausted. How are you expected to get any time to do any exercise? So we know that metabolic dysfunctions alter sleep, so we have to start by regulating those metabolic inflexibility, supporting cortisol, supporting insulin, supporting leptin, supporting inflammation, all to support chronic sleep deprivation. And there's just your references for you. Now we need to go on and think about, well, other drivers of neuroinflammation, periodontal diseases, and we know from looking at CIREX, Alzheimer's associated immune reactivity screen, that is one of the bacteria that they look for is an oral pathogen. So much research has been undertaken to look at oral microbiome and Alzheimer's disease. Dr. Victoria Sampson, who is on the advisory board for In Vivo and their oral microbiome assessment, has just released a paper on oral microbiome and Alzheimer's. She is amazing. Her level of research is phenomenal. Go away and download her paper. So we know that inflammation is known to play a pivotal role in the process of declining cognition and neurodegeneration. So we have to be thinking about the mechanisms that drive it. And one of these, according to so much research, is oral bacteria creating LPS, creating more inflammatory cytokines, and then in a vulnerable individual, those inflammatory cytokines passing through the blood-brain barrier, driving neuroinflammatory and thus neurodegenerative conditions. This study here, 6-month observational study, concluded periodontitis is associated with an increase in cognitive decline in Alzheimer's disease, independent baseline cognitive state, which may mediate through effects of systemic inflammation. So please, guys, do make sure you're asking your clients about the state of their mouth, maybe running the oral ecologics on their mouth to see what state of bacteria is in there. And interestingly, I run that panel on several people. Like, I just see the hygiene show, I've been given a clean bill of health, and I've run that panel, and it's come out with red pathogens, which are the tip of the triangle pathogens that shouldn't be there. So then I've sent them off to see Dr. Victoria Sampson to go do biofilm disruption work on their mouth. And these are clients that are not presenting yet Alzheimer's, but are presenting with cognitive decline in their younger years, whether that is as simple as I cannot concentrate, or I've got more inflammatory conditions going on. Here, looking back into micronutrients and ADHD, and I keep trying to sort of gel all of the conditions together, looking at foods that have inflammatory responses in there, definitely thinking about food color, avoid glycemic spikes, enhance biodiversity, increase essential fatty acids, and at a minimum, try and remove gluten and dairy from the diet. And for everybody, we've got to be thinking about the impact of sugar and neuroinflammation. Now, this study that I've got out in front here did come from looking at MS, but again, it was a study looking at neuroinflammation. And then here, dietary sugars, not lipids, drive hypothalamic inflammation. So we have to change that standard diet, the SAD diet, the Western diet, and get the sugars out. Research here is showing evidence that ketone bodies derived from fatty acid oxidation are produced during fasting and consumption of high-fat diets can exert broad neuroprotective effects. Moreover, ketone bodies exert both epigenetic and anti-inflammatory effects. So thinking about circulating glucose level, the exact connection between Alzheimer's disease and type 2 diabetes is still in debate. However, poorly controlled blood sugars may increase the risk of developing Alzheimer's. And this strong that evidence that some have called Alzheimer's diabetes of the brain, or type 3 diabetes. And this hypothesis was directly investigated by first examining post-mortem cases of advanced Alzheimer's disease, determining if the neurodegeneration was associated with significant abnormalities of the genes encoding insulin, IGF-1 and IGF-2 peptides, the receptors and downstream signaling mechanisms. So maybe thinking about testing some of these genomic metabolic pathways and then looking at working with those. LifeCode have released a fairly recent metabolics genomics pathway, which is absolutely phenomenal for looking at the pathways involved in regulating glucose, GLUT4, inflammation, mitochondrial damage. Like, that has to be your go-to in any of these clients, and in fact, in any of us. Research here, taken together, our results suggest that intermittent fasting induces an adaptive response in the brain periphery that can suppress inflammation and preserve cognitive function in an animal model of systemic bacterial infection. I will argue that the majority of us should be implementing intermittent fasting. I'm not suggesting that for children, and there are certain vulnerable individuals that you can't do that for, but the majority of us should be thinking about the positive benefits of intermittent fasting. Gluten sensitivity is an abnormal immune response to gluten in genetically susceptible individuals, and they manifest solely with neurological dysfunction. 90% of gluten sensitive individuals have no GI symptoms. So you've got to be thinking about, do we need to remove gluten in anybody presenting neurological conditions as part of an elimination diet? This study here, refined sugars and saturated fat can increase the risk, whereas a healthy diet characterized by high consumptions of fruits and vegetables would protect against ADHD or hyperactivity. Going on to think about key micronutrients in brain health. Polyphenols are known to induce numerous beneficial effects associated with inflammation, neuroprotection, antioxidants, cardiovascular disease, cerebral ischemia, and metabolic disorders. They also regulate learning and memory, prevent neuroinflammation, and modulate neurotransmitter levels. So thinking about how we can incorporate more of these polyphenols in the diet is so important. It should be part of your therapeutic plan, always thinking food first. They will also have dietary impacts on systems in the body, heal, and they can support the blood-brain barrier and the microbiome diversity, which are critical in helping the blood-brain barrier work. Natural compounds that can cross the blood-brain barrier are the most effective agents for lowering neuroinflammation. So those top players are resveratrol, curcumin, apigenin, catechins, and then sort of dropping down to your luteolins, naringenin, quercetin. Polyphenols do not have the same impact on everyone, and polyphenols only become active when they're converted to metabolites by enzymes in the microbiome. So different microbiomes have different responses to polyphenols. And here's the research. They're not able to cross the blood-brain barrier until they're metabolized by the microbiome metabolites, hence why it's so important to be working on that diversity. Children with ASD display an elevation in interleukin-6 and TNF-alpha levels in serum have been linked with deficits in sociability. However, there is evidence to suggest that altering the diet may be able to curtail this aberrant immune response in autistic spectrum disorder. As discussed in this paper, elevated levels of interleukin-6 are associated with social deficits. However, treatment with luteolin, a natural flavonoid, helps to normalize interleukin-6 by inhibiting its release from mast cells. Interaction between the poor gut microbiome and the brain is so interwoven but so upregulated as part of our Western diet. And what I know, having worked with individuals, youngsters with autistic spectrum disorder for more than 2 decades, they are the hardest ones once they have a very restrictive diet to alter. I hear that. And today is not a lecture about behavioral changes, like how to do that. That's what I used to do on the ground, on the floor, with individuals and working with. And that's certainly something we do in my clinic, is be setting parents up with the skills of how to make those dietary changes. Tonight is just about the what we're encouraging people to do. But remember that what happens, it goes in, will orchestrate alterations in those neuroinflammatory cytokines. So working at the gut, working at what goes into the mouth is so important. Now, DHA is the most abundant fatty acid in the brain, regulates several key functions at the phospholipid membrane of our neurons. With significant inflammation, cell membrane DHA breaks down to modulate neuroinflammation. DHA can cross the blood-brain barrier after oral ingestion and may be required during times of neuroinflammation. It is absolutely vital if you're suspecting neuroinflammation to get omega-3s with a good amount of DHA in there, including into young children. I'll use it from 6 months of age. Here at NutriAdvance, we have one that's aimed at children. Flavoursome, and it's got a really nice EPA to DHA ratio. More research for you here on omega-3s. I'm going to leave you to read it in your own leisure. So here, thinking about that interaction between the gut microbiome and omega-3 puffers and the effect on ADHD symptoms. The imbalance in the omega-3 to omega-6 ratio leads to a state of neuroinflammation and a consequent disruption in the dopaminergic system, which is what you can see with the black arrows in the middle. Dopaminergic dysfunction is one of the main factors contributing to ADHD core symptoms. Alterations in the microbial composition have been associated with ADHD symptoms, apparently via the influence of the gut microbiome and neurotransmitters, so microbiome gut-brain axis. The administration of probiotics may boost the concentrations of omega-3 puffers, and this would correct the omega-3 to 6 ratio in favor of a higher omega-3 anti-inflammatory, thus supporting the dopaminergic neurotransmitters and reducing neuroinflammation. Amazing, simplicity when we think about it. You need a healthy gallbladder, though, to absorb essential fatty acids, and it might be that has been influenced by SIBO, small intestinal bacterial dysbiosis, causing deconjugation of the bile acids. Again, that would make us think we might need to work on bacterial dysbiosis as an urgent, acute part of our protocol. Symptoms of bile stasis might be bloating after fatty or fried meals, burping after fatty meals or fish oil, referred pain up into the shoulder blade, floating stools. So what we need to be thinking about: brain, mitochondria. What nutrients are vital for mitochondrial function? You've got your B vitamins, particularly 1, 2, 3, 5, and 6, manganese, magnesium, biotin, vitamin C, D, and E, copper, zinc at the right ratio, calcium, CoQ10, potassium, carnitine, and then antioxidants that protect damage to the mitochondria, NAC, glutathione, ALA, resveratrol, curcumin, CoQ10. And then thinking about those polyphenols again that activate the mitochondrial, your resveratrol, your quercetin, your EGCG, apigenin, luteolin, naringenin. And then what else do we need to really support ATP synthesis? D-ribose, medium chain triglycerides, butyrate, carnitine, CoQ10, nicotinamide. They are all vital. I'm not saying we put all of those nutrients in. I'm saying we need to be investigating where deficiencies fall in each individual. And then, like I said, we absolutely have to be thinking about the gut-brain axis, thinking about pre and probiotics, potential infections, and the only way to really be able to ascertain an individual's microbiome is through testing, because if not, you are constantly guessing. And then we've got to work on that intestinal homeostasis and the maintenance of gut health, which we know requires an appropriate balance between immune effector cells and regulatory pathways. T regulatory cells are abundant in the intestine, and they play a really important regulatory role, particularly through the induction of inflammatory or anti-inflammatory cytokines. But they also, we need to be able to regulate those T regulatory cells, and we need short chain fatty acids, we need fiber, we need butyrate from, if tolerated, organic butter to be able to support those cells. We need magnesium as a neuroprotective agent. A review of its use in the fetus, term infant with neonatal encephalopathy, and adult stroke patients showed the high need for magnesium in the brain. Again, we've got a really nice one aimed at children, aimed at teens, whether that's to help them with sleep, whether that's to help them with concentration. Research here looking at magnesium sleep. Then moving on to glutathione, which I've already mentioned. I've just said how important it is in mitochondria. It's really important in blood-brain barrier integrity, supports intestinal barrier integrity, supports T regulatory cells, supports nitric oxide balance. We know how important it is in phase 2 detoxification. It's a natural chelator. So we really need to be thinking about what are our clients' serum levels and what can we do to correct it. Curcumin entry through the blood-brain barrier, I've already mentioned to you. There's the research. Ginkgo biloba is currently the most investigated and adopted herbal remedy for cognitive disorders and for Alzheimer's disease. And here's a research paper looking at ginkgo and its effective and safe complementary therapy in the treatment of childhood ADHD. Now, whilst it's limited in its research, there is evidence starting to become available. Resveratrol restores tight junction proteins, and looking at leaky blood-brain barriers as well as leaky gut barriers. It's really important. Compared to healthy controls, ADHD children had significantly lower serum levels of B12, folate, B6, ferritin, monounsaturated fatty acids, but higher levels of serum saturated fatty acids, omega-6 to omega-3 fatty acid ratio, and inorganic phosphorus concentration. Children with ADHD had more intake of nutrient-poor foods such as high sugar and high fat foods, and had less intake of fruits and vegetables and proteins. Chicken or an egg? Moving on and thinking about testing homocysteine. Homocysteine is something I would always test whether somebody's presenting with a more acute alteration in cognitive function, and I've ruled out some of the other functional drivers. Whether they're presenting with Alzheimer's, I also test it in children and see raised levels, or in fact too low levels in some children with ASD, and you want the sweet spots. It's vital to be tested vitamin D level. Vitamin D deficiency was significantly greater in children with ADHD. We mentioned about exercise for sleep. Preclinical studies, the positive effect of exercise have been related to increased levels of neurotropic factors, elevated expression of anti-inflammatory cytokines, and reduced levels of pro-inflammatory cytokines. It's really important to get that exercise in there as a powerful tool. And it's about balancing out between intensity and duration to be protective against neuroinflammation. You don't want them working out, you don't want them over-exercising, because that can drive inflammation. So you really want to ask a client how they respond to exercise, how they are after the events. Electromagnetic fields. So we've got to be thinking about EMFs that are around us all of the time now, 4G, 5G, and the impact that could have on blood-brain barrier permeability. So what can we do? Because we can't change the masts. We can reduce Wi-Fi router exposure, turning it off at night, using Ethernet cables to wire in, especially if you're on the device all the time. It's like, why can't that be wired in? It doesn't mean you can't have Wi-Fi in the house, but it means you can minimize the exposure. Keep your phone on airplane mode when you're not using it. Not using earbuds, and using Wi-Fi friendly, wired speakers like air tubes. Use laptop on battery mode rather than it being plugged in. Use wired mouse and keyboard rather than Bluetooth. Create a sleep sanctuary where there's no Wi-Fi in the bedroom at all. Getting one of those Wi-Fi monitors, walking around your house and seeing where your exposure is, and you will be shocked at what is driving it. Like your hair dryer. Most of us think about our mobile phones, maybe games consoles, but even your bedside lamps being left plugged in is going to cause a spike in one of those monitors. So I've mentioned a few testing as we've gone along, but just want to sort of add in my go-to it when I'm thinking about neuroinflammation and neurodegeneration. I'm a big lover of Cyrex testing, their Array 12, looking at the different pathogens associated with immune reactivity. Mold testing. This is the old Great Plains, the new Mosaics Labs mycotoxin test. Alzheimer's associated immune reactivity screen. I don't just do this in Alzheimer's. I did a whole heap of these in COVID, where people were getting neurological symptoms from COVID, or post-vaccination, where people were getting like tingling down their arm that went on for a few weeks or months. I do this on people who've got ApoE34 or 4/4 positive, to look at any risk factors that we need to be addressing. Definitely stool testing. The FDX brain check that looks at all of the marks I talked about, thinking about fasting glucose, fasting insulin, aluminium levels, homocysteine levels, HSCRP, as well as just CRP. Cyrex Array 11 to look at chemical immune reactivity screen. Metabolomics to look at mitochondria, as well as those oxidative stress levels, as well as nutrient deficiencies, that all ecologics that I mentioned. Sleep apnea assessment to see if somebody is deprived of oxygen during their sleep. So as always, I just want to run through a case study, and I'm conscious we start a bit late and I'm coming up to the hour. So let's just whiz through this case and you will have my notes. Marie is a 46-year-old woman diagnosed with ADHD following a change in work where she struggled to show flexibility. Her mother had recently been diagnosed with Alzheimer's at the age of 73. She was concerned about her lack of concentration, lack of organisation, which she felt worsening since her 40s. She had a long-standing history of gut symptoms. So we plotted a timeline. Adult onset ADHD diagnosis. She'd been started on ADHD meds, and they'd made her IBS worse, so she stopped them. So right back, family history of autoimmunity, maternal aunt with celiac disease, and a cousin with type 1 diabetes. She was the youngest of three. Her brother had died in a horrific accident, and her mum had never been the same since. Her mum was taken, mum had a nervous breakdown, and she went to go and live with an aunt. Actually, sorry, also before that, pregnancy described as reduced movement, blew at birth, turned upside down and banged on the back. And her dad had been a smoker. So those maternal exposures were really quite high. She'd been abused. So she went to go and live with her aunt at the age of 5, and she was abused by her uncle. She went on the OCP at 15, lots of sexual relationships. She'd lost all sense of self-worth. She got married at the age of 28, where she started to turn her life around. She had had tonsillitis, treated with antibiotics multiple times, tonsillectomy at the age of 10, STD treated with antibiotics at 18, and abortion at 23. She had COVID, more recently treated with antibiotics for post-COVID chest infections, IBS type symptoms from the age of 23. Struggling with concentration, on and off antidepressants for 10 years, but didn't work. Changes to a menstrual cycle, 28-day cycle becomes 16-day cycle over 6 months. Quick review of her systems: IBS with diarrhea for 10+ years, lack of diversity in her diet, frequent antibiotics, long-standing history of trauma, her brother's death or abuse from her uncle, OCP from the age of 15 to 23, shortened menstrual cycles, no respiratory symptoms, eczema on her hands since 30s, but I did question whether it was actually contact dermatitis, some anxiety worse premenstrually, ADHD and low mood. I put all under nervous system. Under musculoskeletal, more stiff in spine and pelvis over the last 5 years, so some mild inflammation. Detoxification, alcohol consumption had been very high, but not for the last 10 years. Lack of liver supporting foods, like I said, no diversity. From a cardiovascular risk, increased VAT. So her diet was very high in refined carbohydrates, no diversity, didn't just lack it, there just wasn't any. She ate carrots, sweet corn and peas, they were her vegetables. Breakfast was 2 black coffee and a slice of white bread toast. Lunch was a meal deal that she bought. Dinner was either a takeaway, a ready meal, or highly processed, like throw it in the oven job. Snacks, biscuits, cakes and sweets. She drank 10 mugs of coffee daily, 2 cans of Coke and an occasional energy drink. Her job was stationary, so it was inactive. Does work, sorry, I should say walk to work and gets a lift home. So a 45-minute walk a day. Sleep often late to bed, 11:30 to 1, watching TV. She struggles to wake up in the morning. No hobbies other than walk to work, no exercise, loads of screen time, loads of EMF. So you can see antecedents, triggers, and mediators. I put them into a table there for you. So we started off with adding some fiber and trying to switch our white carbs to whole grain, adding in a daily smoothie and adding in water, which she didn't have any of, other than, well, she didn't have any. What she convinced me it was in her coffee, which we all know wasn't really hydrating fluids. And to try and get her coffee down over the next 4 weeks to ideally 3 daily. I put her on 3 grams of fish oil, and I also used a highly absorbable magnesium glycinate with theanine, taurine, and glycine. I did a GI effects, I did a metabolomics, and I did a Dutch test. So we can see that her commensal balance is as far to the right as can be. She's got very low levels of short chain fatty acids, very low levels of butyrate, and elevated levels of fecal secretory IgA. Her commensals lack diversity, and there is some potentially pathogenic bacteria and a bit of overgrowth of fungi there. She'd also got low levels of Dientomoeba fragilis. Estrogen, she's very estrogen dominant, E1, E2, E3, elevated. Testosterone is also higher than expected, and progesterone is low. So very, very estrogen dominant with higher percentage. You can see here 12.2% going down that 4-hydroxy. So that's more likely to be creating reactive quinone damage. Her melatonin was good. Her cortisol was low. Sorry, her metabolized cortisol was low. Her free cortisol, she hasn't got that spike of, she hasn't got that cortisol awakening response. And then you could see in her FDX that her glucose is elevated, her HbA1c is elevated, her insulin is elevated, her protein is on the floor, thus her globulin is on the floor, so low immunoglobulins. Her GGT is elevated, so 125. Is elevated, particularly her LDL cholesterol, avoid not bad. Homocysteine is really elevated, 17, chest CRP near 4. So inflammation, we're thinking hyperventilation going on, low vitamin D. So plan 2, choline and alpha-lipoic acid for blood sugar balance, to support the 4-hydroxy, the downregulation of 4-hydroxy. Carried on with a high-strength omega-3 fish oil. Added in ashwagandha, an adaptogenic herb. And I put a protocol to incorporate berberine and some support with milk thistle complex and glutathione. Then vitamin D to support the deficiencies. She came back to see me for 4 weeks, and there was no IBS. Oh no, IBS-D had reduced at that point from 4 to 6 bowel movements to 2. Her sleep was now 8 hours per night. low mood less, and her cycle had slightly increased to 20. Plan number 3, reduce her raised cholesterol with plant sterols and CoQ10 to support GI function with gut healing, glutamine, vitamin A, and some antioxidants in there to reduce her homocysteine with B vitamins, carry on with vitamin D, but drop it down to 3,000 IU a day, carry on with the broccoli, the omega-3, the ashwagandha, and the glutathione. She see me 8 weeks later. Her gut symptoms improved 9%. She improved hormone balance up to 26-day cycles, still struggling with concentration and being able to organize herself, significantly less anxiety and low mood. So we finalized the 4R protocol with some digestive enzyme support before a meal and a live bacteria supplement with vitamin A and vitamin D in there. Carried on with the cholesterol support and carried on with all the other support. Also added a ginkgo because we're now focusing on concentration. So 12 weeks later, came to see her GI symptoms remained stable. Her hormonal imbalance was now 28 days, and she'd been on a course aimed at ADHD around organisation. She feels she is making progress on managing ADHD so it can serve her, not work against her. So the final plan was food sources, pre and probiotics, 1,000 IU of vitamin D, broccoli extract, carry on with the fish oil, and carry on with the ginkgo. And whilst it was a very quick whistle-stop tour of what we did, that has potentially, and nobody will know the truth here, reduced neuroinflammation to reduce the trajectory of where that story could go. She will need ongoing support from a functional medicine point of view, but I would wholeheartedly imagine we have made a difference. And that's what all of this is about, making a difference. So thank you so much for your time this evening, and I'll hand you back to Sarah.
So thank you very much, everybody. And Joe, I think there was just one more slide with the offer code for today. So as a thank you for listening, you get access to a 20% off your next order from the Neuro-Advanced website using the code ICANWeb20. We will send that out also. I'll forward it to Ruby and she can send that out with all of the follow-up, which will contain your certificate and the recording. Also, if for any of the questions that we haven't been, I know we were a little over, so any of the questions we don't have time for today, Joe will answer those and we'll send those out with the recording also. And just to let you know that if you have any questions after today about how Nutri approaches things, we go into a bit more depth in terms of our protocols, so you can see what inside our sort of thought process of where we would go for 5R, for Alzheimer's, for liver detox, that kind of thing, blood sugar balance. There's lots and lots on our website available behind a practitioner login. So do please check those out, or you can book a 10-minute slot or longer to discuss different cases and things like that. So you just need to go to the /advice page, and then you'll be able to book an appointment with one of our advisors, our practitioner advisors. So thank you very much, everybody, for listening, and have a good night.